infections, local causes like infections, neoplasm like polyps or carcinoma of the cervix, could be valve varicosities, could be when a mother is in labor, what you call heavy show. Another differential diagnosis is a ruptured uterus. Okay, so what kind of infections can cause late pregnancy bleeding? Anyone? Just unmute and tell me what kind of infection can cause a mother to bleed when she's after 28 weeks of pregnancy. Anyone? Just unmute and answer my question. Any attempt?
Disease.
What am I talking to? Who am I talking to? What's the answer?
Pelvic inflammatory diseases.
Which one?
PIDs.
PID is far-fetched. Most likely does not present with vaginal bleeding. Another attempt, someone else? It's a very common infection in pregnancy which can cause bleeding. Which one is this?
Choriamnionitis.
Which one?
Choriamnionitis.
Choriamnionitis, far-fetched. Okay, another attempt.
STI.
Which one do you have in mind?
Chlamydia.
Okay, not chlamydia as such, but maybe I can answer this for you. Candidiasis, you know, yeast infection, fungal infection. It can cause inflammation and they itch and can present with PV bleeding. So that is one of the causes. Also, local causes like vaginitis, cervicitis can cause late pregnancy bleeding. So in terms of the prognosis, it's an obstetric emergency. When a mother is bleeding after 28 weeks, we take it as an emergency. It can easily lead to maternal mortality, maternal death. The fetal outcome is usually very poor. Perinatal mortality is also very high. And the mother can progress to a state of shock or obstetric collapse. What are the principles of management? Is to present these adverse outcomes that we have just mentioned, both maternal and perinatal. So you're supposed to fix an IV line. When you're doing that, draw blood for grouping and cross-match. And you're supposed to do this before shock sets in, because if it sets in, you're not likely to get that venous access. So when you see them, rush and fix an intravenous cannula and draw blood for grouping and cross-match. And only after that would you consider the aspects of management. So a mother comes to you, she's bleeding. The first thing you do is to fix that line as part of the resuscitation. And this IV line, it's not just an IV line. What is so specific about this IV line? Especially the groups rotating in obstetrics. Can you remember Sharon? What is so specific about this IV line? Anyone?
It should be a large bore IV line so that to allow for the...
Thank you very much. For high volume, if it's fluid or blood, you can transfuse or give fluid in high volume. So large bore cannula. Most of the time we do actually 2 of them. Thank you very much for that answer. So assess the patient's general condition, get the vital signs, get a quick history, not a detailed history, the one taken by students, just a quick one. Do a quick general examination, do an abdominal examination, assess the state of the fetus, and do a speculum examination. So supportive treatment, treat the shock, raise the foot of the bed, okay? Give plasma expanders, example is dextran. Give blood if available, and also start the patient on oxygen, and transfuse if this mother has lost a lot of blood. You can also consider hematinics in some cases. Why are we raising the foot of the bed? Anyone? Just unmute and answer. Why are we raising the foot of the bed when the patient is in shock?
To enhance venous return.
2, can you be more specific?
To increase the venous return to the heart.
Okay, a good attempt. Anyone else?
To allow for perfusion to the brain.
Thank you very much. Oxygen perfusion to the brain. Okay? That's very important. You know, brain is everything. So you're sparing everything else, oxygen supply to all other organs. You want to shaft it to the brain. Okay? So that's why you're lifting the foot of the bed. Okay? So prognostic diagnosis, it can be mild, moderate, or severe. It can be placenta previa, placenta abruptio, or any other, as we have discussed earlier, and make a decision at projected management plan, whether it's conservative or you want to do immediate intervention. So placenta previa, what is placenta previa? This is when the placenta is wholly or partially placed in the lower uterine segment. The normal position for the placenta is upper fundal area, upper segment of the uterus. So when this placenta, either part of it or the whole placenta, it's placed in the lower uterine segment, that is what we call placenta previa. Why is it important? It's because the mother is likely to bleed as a result of premature placental separation. How does the placenta separate? Through shearing effect of the placenta, and this is because of the formation of the lower uterine segment taking up the cervix due to uterine contractions. We have 2 types of placenta previa. One is minor and the other one is major. Okay, minor, you can actually have a normal delivery, vaginal delivery. But if it's major, you have to go for cesarean section, abdominal delivery. Don't allow for vaginal delivery in major placenta previa. Okay, we classify placenta previa into 4. And how do we do this? We take the patient for what we call examination under anesthesia. There are 4 types of placenta previa which are recognized. I'm going to request, cannot see most of you. Just a minute. Sharon Chebet, you there?
Yes, I'm there.
Just read the slide for us, the definitive diagnosis.
Made at the definitive diagnosis, it's made at an examination and anesthesia, and there are 4 types of placenta previa recognized. The type 1, placenta reaches the LUS but does not encroach on the internal cervix of the OS.
Lower uterine segment, LUS.
Lower uterine segment but does not encroach on the internal cervical OS. The type 2, placenta encroaches on the internal OS but does not cover it. And then the type 2 is further divided into type 2 anterior, if the placenta is anterior, and type 2 posterior, if the placenta is posterior. The type 3, the placenta covers the internal OS but not completely. And then the type 4, the placenta covers the internal OS completely, even if it was to reach the full dilation.
Thank you very much. Those are the 4 types. Types 1, placenta in the lower uterine segment, but does not encroach the internal cervical os. OS is os, that is an opening on the cervix. We have an internal os and external os. So here we are talking about internal os. The type 2, it encroaches the internal os, but does not cover it. Then we have 2 types, anterior and posterior. And type 3 covers completely the internal os, but not, covers internal os, but not completely. Okay, so type 2, it reaches but does not cover. But type 3 partially covers it. Then type 4 fully covers the internal os, even when you have full cervical dilatation. That's how you classify the placenta previa. So type 1 and 2 anterior, they don't obstruct, they don't cause for obstruction. So type 1 and 2 anterior, you you can have vaginal birth, especially if the patient is not actively bleeding. Type 2 posterior, it impedes on the descent of the presenting part on the sacral curve during labor. So type 3 and 4, you don't allow for vaginal delivery and you take them for emergency cesarean section. So how does the pathogenesis, how does it come about? What are the theories that explain placenta previa? Let me hear from who? Benta. Benta? Otieno, just read the slide for us as it is.
Okay. Pathogenesis, several theories. Rapid embryo development reaches the uterine cavity before the endometrium is receptive. Then previous endometrial damage or poor vascularization, multiple uterine scars, previous DNC, fibroids, then multiple pregnancy, the large placenta engages to the lower uterine segment, then raising maternal age.
Thank you very much. So those are the theories which have been hypothesized to cause placenta previa. Rapid embryo development, where the embryo reaches the uterine cavity before the endometrium is receptive. Previous damage to the endometrium through multiple uterine scars like multiple cesarean sections. Previous dilatation and curettage, that is DNC. Uterine fibroids, okay, which prevent now the placenta from going up. Multiple pregnancy, we have a large placenta and raising maternal age. So how do these patients present? Clinical features. They have, in bold, in capital letters, painless vaginal bleeding. Okay, it's not painful, it's painless. And this is often after 36 weeks of gestation. I mean, before 36 weeks of gestation. The first hemorrhage is usually less severe, and we term it as warning hemorrhage. The blood, if you look at it, is usually fresh and bright red. Pain is not a feature. Please remember that. General condition of the patient is commensurate with the amount of blood loss. If she has lost a lot of blood, she's going to be in shock. If she has lost minimal blood, she's going to be stable, and the vital signs are going to be almost near normal. When you examine the abdomen, it's non-tender. The size of the uterus corresponds with the gestational age. If it's 34 weeks, you can get a fundal height of 32, 34 weeks. The presenting part is usually high because the lower part is occupied by the placenta. Malpresentation like breech is very common. Oblique lie is also very, very common. Pelvic examination, remember, you don't do a digital examination for a patient who has PV bleeding in third trimester. What you do is speculum examination. And in this placenta previa, the fetus is always in good condition, and you're going to compare this with another form of APH. Why do we say that you should not do a digital examination, vaginal examination? Anyone? Why do we say that VE is a no-go zone in placenta previa? Let me hear from who? I have all your names here.
You might rupture the uterus.
No. Charles Wanjohi?
You could cause infections.
No. Anyone else? Unmute and try to answer. No, that's no.
May cause severe blood loss.
Thank you very much. Okay, remember the placenta is just next to the os. So if you put your digit there, the fingers, you might actually, your fingers might pass through the placenta. The placenta, you remember, is highly vascularized. You've seen the placenta in the delivery room. So you can imagine if you interfere with it with your fingers, how much bleeding you're going to cause. So we say never do a digital examination for a patient you suspect has placenta previa. Instead, you do what? You do speculum examination. Okay? I hope that is clear. So differential diagnosis is abruptial placenta and local causes of bleeding we had discussed earlier. How do you do definitive diagnosis? You can do what we call placental localization, okay? And this is very important for the mode of delivery. You can do this using an ultrasound, which will tell you where the placenta is. You can also do what we call EUA with double setup. And I'm going to ask you guys to go and read what is EUA with a double setup. Those who are writing notes, please note that. Go and find out what is EUA with a double setup. So management, what are the principles? If the patient is at or near term, consider delivery. The mode of delivery depends on the bleeding and type of placenta, as we had discussed earlier. If the hemorrhage is life-threatening, at any gestation, you do emergency cesarean section. If not, or near term and hemorrhage is not life-threatening, you can do conservative management. So conservative management, what are the objectives? You want to achieve fetal maturity without compromising maternal safety. Put this mother on bed rest, give her sedatives, you remove blood for grouping and cross-match and keep about 2 to 3 units ready, just in case the mother bleeds again and go into shock. You can give lung maturing drugs. In our setup, Mama Lucy will give dexamethasone and deliver if there's torrential hemorrhage at any one time, if there's significant bleeding after 34 weeks of gestation, or when the patient gets to 37 weeks of gestation. So if you are doing conservative, you're supposed to abandon that conservative and consider delivery under those 3 conditions: severe hemorrhage, significant bleeding after 34 weeks, or when the mother gets to 37 weeks of gestation. So the mode of delivery, I said, is either vaginal or cesarean section, and you do you at a double setup, which you guys are going to find out what it is. What are some of the complications of placental previa? There's increased blood loss at placenta cesarean section, and this is because sometimes you go through that placenta and it bleeds a lot. These mothers are also at increased risk of postpartum hemorrhage. After delivery, whether normal or cesarean section, they have an increased risk of postpartum hemorrhage. The other form of APH is what we call abruptio placenta. What is abruptio placenta? This is premature separation of a normally situated placenta. Unlike placenta previa, this was normally situated. It's in the normal position, the fundal. It's not in the lower segment, but it separates prematurely. What are the 2 types? We have concealed and revealed. Concealed, the bleeding is confined in the retroplacental space. Revealed, the blood trickles from the retroplacental space through the placental margin, and placental abruptio is often recurrent in subsequent pregnancies. So one of the risk factors for abruptio placenta is a history of placenta previa in previous pregnancies. Pathogenesis. What is the pathogenesis? Let me get this from Doris Nyambura. Just read the slide for us. Doris?
Pathogenesis of abruptio placenta faults at implantation may result in an area of weakness, decidual infarct, extravasation of blood into the myometrium responsible for woody hardness of the uterus, excessive extravasation with resultant myometrial damage leads to cavalier uterus.
Thank you very much. So that's the pathogenesis. We have faulty implantation, so that area of implantation is weak. During implantation, you can have some infarct, what you call decidual infarct. You can have extravasation, that is blood vessels going into the myometrium. That's when you palpate, you get woody hardness, or excessive blood vessels into the myometrium, causing some damage in what is going to lead to Couverale uterus. Etiological factors, trauma. Okay, external blue, the patient can fall from height, from boda, okay, or in the process of a process we call external cephalic version. We do that for those who are presenting breech. Another risk factor is hypertensive disease in pregnancy, PET. The other one is nutritional deficiency, especially folic acid. The other one is blood multiplicity, those who have had more than 3 kids. Previous abortions, preterm labor, intrauterine growth restriction or fetal malformations, or previous history of abruptio of placenta. So those are the risk factors for abruptio of placenta. What are the clinical features? Severity of symptoms depends on the amount of retroplacental bleeding. 50% present with classic clinical features, that is hemorrhage. And this blood, unlike the placenta previa, is dark because it has been retained for long. And the amount of bleeding does not commensurate with the degree of anemia. What does this mean? You get a mother who is very anemic, but what she complained of is little bleeding, unlike in the abruptio placenta. When you do abdominal examination, they usually complain of pain. So you're going to get tenderness when you palpate. And the abdomen is tense, and the fetal parts are very difficult to define. So when you do examination, abdominal, you get the uterine size is more than the dates because the bleeding is inside, including to the myometrium. The fetal heart rate, unlike in the placenta previa, are difficult to auscultate. And actually, you might actually have an AUFD. The general condition, the degree of anemia and shock don't commensurate with the apparent blood loss. What are the differential diagnoses? Placenta previa, local conditions we had mentioned earlier, ruptured uterus or acute polyhydramnios. So this table is very, very important for us to differentiate between different causes of late pregnancy bleeding. So I'm going to request who is going to do this for us. Arias Muturi. You're there. Arias, just read the
Yes,
slide
sir.
for us, the table for us, yes.
Okay, the comparison of placental previa and abruptio placenta. In bleeding, in placenta previa, it is bright red, recurrent, painless, usually no labor. In abruptio placenta, it is dark, continuous, pain is present, often associated with labor. In terms of the uterus, in placenta previa, it is relaxed and no tenderness. In abruptio placenta, it is tense, tender, and painful. In relation to shock or anemia, in placenta previa, it is proportional to blood loss. In abruptio placenta, it is disproportionate to blood loss. Fetus, placenta previa, parts are easily palpated. The fetus is often alive, and malpresentation is common. In abruptio placenta, it is often difficult to palpate, dead in 50% of instances, and malpresentation is uncommon.
Thank you very much. So remember, if you're going to remember anything in my lecture, just remember this table. It's very important that you differentiate between the two. What are the complications of placenta previa? Coagulation disorders. This is due to release of the proplastrin from damaged tissues, and consumptive coagulopathy, consumption of clotting factors by the retroplacental clot. Due to the heavy bleeding, which sometimes is concealed, you can have pituitary necrosis, okay, also because of shock. Renal failure due to shock and DIC. Postpartum bleeding, it's very common. This is usually due to uterine damage, uterine atony, or coagulopathies. Fetal complications, these are influenced by the degree of placenta separation and degree of shock or stroke anemia. You can have intrauterine fetal hypoxia, intrauterine fetal death, IUFD, or preterm delivery. Management. Once a diagnosis is made, the following should be done. Do the resuscitation, ABC, treat the shock, take care of a hypoxia, manage the DIC, and delivery should be effected. If the fetus is alive, you consider CS, is usually preferable. If the fetus is not alive, you can consider vaginal delivery. But if the hemorrhage is life-threatening, even with a dead fetus, you do cesarean section. Manage coagulation status, and usually because of this risk of shock and renal damage, you monitor urine output. Okay, how do you monitor urine output? Let me hear from Doris Nyambura. I think Doris had talked. Daisy Kasiva. How do you monitor urine output?
You catheterize the patient.
And then once you catheterize, that is very good.
You measure the urine output volume.
Against? It's measured against?
Against the fluid intake.
Thank you very much. Whatever she's taking and whatever is coming out. If whatever she's taking is more than what is coming out, it's minimal, less than 500, that is very good here. Okay? In 24 hours. So urine output is very important for you to monitor. Yeah, any question? That's the end of my lecture. So you've agreed you go read on your own the EUA and double setup, what it is, and also go read on your own the postpartum hemorrhage. If you get time, you might cover that, but it's important that you cover it because that is the leading killer of women in obstetrics. So any question, you can unmute and ask on our topic today.